Welcome back to The Deep Dive. Today, we're tackling some really critical, maybe even complex, agents in the antimicrobial world.
That's right.
We're aiming for a true mastery-level understanding of three specific families. We've got the fluoroquinolones, the folic acid antagonists, and the urinary tract antiseptics.
Mm-hmm.
And if you're serious about this field, really getting the nuances beyond just the names, well, that's essential.
Absolutely. That's our mission today. We want to go way beyond just basic definitions.
Right.
We need to get into the mechanisms, really understand the generational differences, and critically, the adverse effects and resistance patterns. These things really dictate how we use them now.
So it's not just about remembering facts.
No. It's about professional level synthesis.
Yeah.
Really putting it all together.
Okay, let's start with the fluoroquinolones, the FQs. We should probably set the stage a bit historically.
Good idea.
Their story starts, maybe surprisingly early, back in the 60s with nalidixic acid. But the real FQs, when they emerged, wow, they felt revolutionary.
They really did.
Yeah.
Because chemists made these clever structural tweaks. And that massively expanded their spectrum. What bacteria they could hit. Plus, it improved their pharmacokinetics. Better absorption, getting into tissues better. They became the go-to drugs very quickly.
And that popularity, ironically, kind of led to their current problems, didn't it?
Exactly. Their downfall, in a way.
Yeah.
They were so good, seemed so well-tolerated at first, and so broad that they got used everywhere. Human medicine, agriculture, globally, just massive overuse.
Which created huge selective pressure.
Intense pressure. And the consequence, well, now FQs are largely second-line options.
Right.
We're seeing scary resistance rates, gram-negatives, gram-positives. We know they increase the risk of things like C. diff infections. And crucially, we identified those really serious, sometimes permanent side effects, the ones that led to the big boxed warnings.
Okay, let's dive deep into that first group then, fluoroquinolones, the DNA disruptors. Their mechanism, you called it a surgical strike on DNA. That's quite a description.
It really fits. They are bactericidal, they kill the bacteria outright, and they do it by messing with DNA replication in a very specific way. They don't just cause random damage, they target the enzymes bacteria rely on to manage their DNA.
It's like attacking the maintenance crew for the genetic code.
Precisely. Imagine bacterial DNA as this incredibly long, tangled rope. When it replicates, it twists up like crazy, creating enormous torsional stress.
Okay.
Bacteria need two key enzymes, type 2 topoisomerases, to handle this.
The first one being DNA gyrase. What's its job exactly?
DNA gyrase basically relieves that twisting stress. It snips the double-strand DNA, passes another section through the break, and then reseals it, introducing negative supercoils.
Kind of like proactively untwisting the rope ahead of the machinery.
Exactly. Keeps everything running smoothly. If gyrase stops, replication just grinds to a halt.
And the second enzyme, topoisomerase 5.
Topoisomerase CRV comes in a bit later. Its main job is to help separate the two newly replicated daughter chromosomes, which are often interlinked and tangled. It untangles them.
So the FQ gets into the bacterial cell, usually through porin channels,
Right.
and binds to these enzymes. But how does it stop them? It interferes with DNA ligation.
That's the key step. The enzyme does its job. It cuts the DNA strands like it's supposed to. But the FQ molecule basically traps the enzyme right at that moment, stuck to the broken DNA ends. It prevents the religation, the resealing step.
So it's like jamming the repair mechanism mid-process.
A fatal jam. This leads to a buildup of permanent double-strand DNA breaks all over the chromosome. The cell tries to fix it, but it can't. It triggers cell lysis. The cell just falls apart. Elegant, but brutal.
And what's really interesting is the selectivity. Which enzyme they target determines which bacteria they hit hardest.
Yes, that's fundamental. For gram-negative bacteria, think E. coli, Pseudomonas, the main target is DNA gyrase.
Okay.
But for gram-positive bacteria, like staph and strep, the primary target shifts. It's topoisomerase TOFI they need to inhibit effectively.
And understanding that difference helps explain the different generations of FQs, right? They were tweaked chemically.
Exactly. Engineered to bind better to one enzyme or the other, or sometimes both, which broaden their spectrum over time.
That evolution is a great example of targeted drug design, trying to improve that topoisomerase inhibition and get the drug into the cell better.
And clinically, we talk about their killing being IU-MIC dependent. That sounds technical, but it's important.
Explain that a bit more. Area under the curve over minimum inhibitory concentration.
Right. It means it's not just about hitting a high peak drug level briefly. It's about the total exposure of the bacteria to the drug over a period of time. That's the area under the curve. compared to the minimum concentration needed to stop its growth, the MIC.
So you need enough drug for long enough.
You got it. You need sustained levels above that MIC threshold to really ensure you kill the bug. This dictates how we dose them, maybe higher doses less frequently, for example.
Okay, let's walk through the generations. Generation 1.
That's your nalidixic acid, very narrow spectrum, mostly just some aerobic gram-negative rods, like Enterobacteriaceae.
And quickly outdated for systemic use.
Yeah, poor absorption, narrow window, didn't last long as a major player systemically.
Then the big leap, second generation. Ciprofloxacin. That's the one everyone knows.
The game changer, absolutely. Cipro got into cells much better.
Okay.
And its spectrum blew up. Suddenly, you could hit tough bugs like Pseudomonas aeruginosa, plus H. influenza, Neisseria, and importantly, those atypical pathogens like chlamydia and Legionella.
So Cipro became the workhorse.
Became the standard, especially for gram-negatives and some other tricky infections for a long time.
Then third generation brings us levofloxacin, and here the focus shifts towards gram-positive.
Exactly. Levo kept that good gram-negative coverage from Cipro.
Right.
But added much better activity against Streptococcus species, especially strep pneumonia, the main cause of community-acquired pneumonia.
Which earned them that nickname.
Respiratory fluoroquinolones.
Yeah.
They also picked up activity against MSSA, methicillin susceptible, S. aureus, Stenotrophomonas multifida, and even some mycobacteria.
And finally, the fourth generation. More specialized. Moxifloxacin, gemifloxacin, delafloxacin. What makes them distinct?
Yeah, this is like hyper-specialization.
Yeah.
Moxi and Gemi have really strong gram-positive activity. And importantly, Moxi also hits anaerobes quite well, like Bacteroides, Fragilis, and Prevotella.
Okay, but delafloxacin sounds like the real standout here.
Delafloxacin is quite unique in this group. It's active against MRSA methicillin-resistant Staph aureus. That's a huge deal.
Wow, okay.
And it also hits Enterococcus faecalis. Makes it really valuable for things like complicated skin infections where those bugs might be involved.
Let's nail down a critical difference here, especially for hospital settings. Pseudomonas coverage. If you need to hit Pseudomonas, which FQs are reliable.
Okay, superfloxacin and levofloxacin, second and third gen, they reliably cover Pseudomonas. That's established.
Right.
But if you look only at that fourth gen group we just mentioned, Moxi, Gemi, only delafloxacin keeps good activity against Pseudomonas.
That's a crucial point. So moxifloxacin, even though it's a respiratory FQ, is a bad choice if you suspect Pseudomonas, like in hospital-acquired pneumonia.
Absolutely not. Moxi has poor Pseudomonas coverage. You wouldn't use it for HAP or VAP, whereas Pseudomonas is a major concern.
Okay, we understand the spectrum now. Let's pinpoint the clinical situations where FQs, despite all the concerns, are still really important, maybe even first line.
Top of the list, non-negotiable. Anthrax.
Right.
Ciprofloxacin is the drug of choice for post-exposure prophylaxis and for treatment. Levo and Doxy are alternatives, but Cipro is the standard.
Okay. What about UTIs?
For urinary tract infections, yeah, Cipro and Levo are still very effective for both simple and complicated UTIs. Provided, and this is a big caveat, local resistance rates aren't too high. You have to know your local antibiogram.
Makes sense. And respiratory infections.
The respiratory FQs, Levo and Moxi, primarily used for community-acquired pneumonia, CAP, because they hit strep pneumo so well.
And this highlights why Cipro isn't great for pneumonia, right?
Yes, exactly. Cipro has a weak activity against strep pneumo, so you generally avoid it for typical pneumonia or even acute bacterial sinusitis. You need that third or fourth gen muscle for reliable respiratory coverage.
What about gut infections? GI issues?
Cipro still holds a niche there. Very good for acute infectious diarrhea caused by common enteric bugs.
So traveler's diarrhea.
Classic use for traveler's diarrhea, yes.
Yeah.
And also for typhoid fever. And one more point on Cipro, if you're treating a confirmed Pseudomonas infection, especially a serious systemic one, you often need high-dose ciprotherapy to overcome higher MICs.
Let's go back to that moxifloxacin caveat you mentioned earlier. It's a perfect example of a detail professionals need to know.
Right. So Moxi for CAP, yes, because of strep pneumo. But as we said, not for hospital-acquired or ventilator-associated pneumonia because it misses Pseudomonas.
Okay.
And there's another layer. Anaerobes, like Bacteroides fragilis, are becoming more resistant to Moxi. So if you have a serious intra-abdominal infection and the patient has had any fluoroquinolone in the last, say, 3 months, you should probably avoid Moxi because of that resistance risk. These are the real-world guardrails on prescribing now.
Now, the flip side, resistance. How do bacteria fight back against these DNA disruptors?
They're clever. High-level resistance is usually chromosomal, meaning it's coded in their main DNA, and it happens mainly in 3 ways.
Okay, number 1.
Altered target binding. This is the most direct defense. The bacteria develop mutations in the genes that make the target enzymes the gyrase gene for gyrase or BARSV for topo4.
Right.
These mutations change the shape of the enzyme just enough so the FQ can't bind effectively anymore. It just doesn't stick well enough to trap the enzyme.
So the drug can't latch on? What's the second way?
Decreased accumulation. Basically keeping the drug out or pumping it out. 2 methods here. They can reduce the number of porin channels in their outer membrane, making it harder for the drug to get in. Or, more effectively, they ramp up efflux pumps.
Ah, the pumps.
Yeah, these are proteins in the cell membrane that actively grab the FQ molecule and pump it right back out of the cell, like a sump pump working constantly.
So the drug gets in, but gets kicked out immediately.
Pretty much cancels its effect. And the third mechanism.
Enzymatic degradation. Less common, but it happens.
Yes, some bacteria have acquired a specific enzyme, actually a variant of an aminoglycoside acetyltransferase, that can physically modify the FQ molecule, adding an acetyl group, which inactivates it.
Let's shift to pharmacokinetics, PK, how the body handles these drugs. This affects efficacy, but also safety and those crucial interactions. Absorption first.
Generally, really good oral absorption. Levo and Moxie are often over 90% bioavailable. Yeah, almost the same effect giving the pill as giving the IV.
But there's a huge catch with absorption, isn't there? Interactions.
A major red flag. Absorption is massively reduced if you take them with things like sucralfate or antacids containing aluminum or magnesium. Also, iron, zinc supplements.
And the big one everyone forgets.
Calcium. And other divalent milk, yogurt, calcium supplements. They chelate the FQ, forming an inactive complex that just doesn't get absorbed.
So you cannot take Cipro with a glass of milk.
Absolutely not.
Yeah.
You'll slash the dose the patient actually receives. You have to tell patients, separate FQs from dairy, antacids, and those supplements by at least 2 hours, maybe even 4. It's critical.
Okay, once they're absorbed, how's the distribution? Where do they go?
Stellar distribution. They get into tissues really well. Bone, kidney, lungs, good penetration. And importantly, they accumulate inside certain immune cells like macrophages and neutrophils.
Which means they can hit intracellular bugs.
Exactly. That's why they're useful for things like listeria, chlamydia, certain mycobacteria that hide inside cells. Good CNS penetration too, though that can contribute to side effects.
Okay, elimination. How does the body get rid of them? This is where that major exception comes in.
This is one of the most important PK distinctions. Most FQs, Cipro, Levo, are primarily eliminated by the kidneys.
Meaning you need to adjust the dose if kidney function is poor.
Correct. Dose reduction needed in renal impairment. But moxifloxacin is the huge exception.
How is it different?
Moxie is metabolized mainly by the liver. It undergoes glucuronidation and sulfation.
So for Moxie,
No dose adjustment is needed for renal impairment. This makes it a go-to systemic FQ if your patient has kidney failure.
but there's always a trade-off, right?
Always. Because it's liver metabolized and doesn't rely on the kidneys for elimination, Moxie does not concentrate well in the urine. So it's a poor choice for treating UTIs.
Okay, let's brace ourselves. Adverse effects. This is where FQs get their notoriety. Those FDA-boxed warnings are serious.
They are incredibly serious, and the effects can be permanent. We have to respect these. The 4 big ones in the box are tendinitis and tendon rupture.
The Achilles tendon is the classic example, right?
That's the most common site, yeah. Then debilitating peripheral neuropathy, nerve damage in the hands and feet, and significant CNS effects.
Like what?
Seizures, hallucinations, anxiety, insomnia, confusion, dizziness, a whole range of neuropsychiatric effects.
Why the tendon damage? That seems so specific and unusual for an antibiotic.
It's not fully understood, but the leading theory relates back to the mechanism. While they primarily hit bacterial enzymes, they might have some off-target effects on mammalian enzymes involved in maintaining cartilage and connective tissue. It seems to disrupt collagen synthesis or repair somehow.
Making the tissue weaker.
Exactly, leading to inflammation, pain, and in some cases rupture. Risk is higher in older patients, those on corticosteroids, or with kidney disease.
Beyond the boxed warnings, what else do we need to watch for? Phototoxicity.
Absolutely. Patients need strict counseling on sun safety. Use high SPF sunscreen, wear protective clothing, avoid excessive sun or UV exposure. They can get severe exaggerated sunburn.
Cardiology concerns?
Yes, they can prolong the QTC interval on an EKG. This increases the risk of potentially fatal arrhythmias like torsades de pointe. So caution is needed in patients with risk factors or on other QT prolonging drugs.
And metabolic issues.
Blood glucose disturbances. Both hyperglycemia and hypoglycemia have been reported, especially in diabetic patients. Requires close monitoring.
Okay, and finally, the drug interactions, particularly with ciprofloxacin. You mentioned it inhibits P450 enzymes.
Yes, Cipro is a moderate inhibitor of CYP1A2 and a weaker inhibitor of CYP3A4.
Meaning it slows down the breakdown of other drugs using those pathways.
Correct. This can lead to increased potentially toxic levels of those other drugs. Key examples you must know include theophylline.
Risk of seizures there.
High risk of theophylline toxicity. Yeah, seizures. Also warfarin. Cipro significantly increases warfarin levels.
Huge bleeding risk. Needs immediate dose adjustment and monitoring.
Absolutely critical. Others include tizanidine, a muscle relaxant, ropinirole for Parkinson's RLS, duloxetine, even caffeine, sildenafil, and zolpidem, Ambien. You have to check for these interactions whenever prescribing Cipro.
All right, let's shift gears completely. We're moving from DNA disruption to metabolic blockade with the folic acid antagonists.
Totally different strategy.
Folic acid is essential, right, for making DNA, RNA, amino acids, the building blocks of life.
Absolutely essential. Without it, cells can't grow or divide.
So the idea is stop the bacteria from making it.
And the key vulnerability we exploit is the difference between us and them.
Okay.
Many bacteria can't just grab folate from their surroundings like we do from our diet. They're impermeable to it. They have to make it themselves from scratch, de novo synthesis.
Ah, so we block their production line, but since we get ours from food, we're mostly okay. Selective toxicity.
Exactly. And the real genius here is the combination therapy. Cotrimoxazole, that's a sulfonamide plus trimethoprim.
Why combine them?
Synergy. They block the folate synthesis pathway at two different sequential steps.
Like shutting down two critical workstations on the same assembly line.
Precisely. Hitting both steps gives a much more powerful effect than either drug alone. It effectively halts the whole process, leading to a bactericidal effect overall, even though the sulfa part by itself is just bacteriostatic, just stops growth.
Let's look at the first part of that combo. The sulfonamides, or sulfa drugs, they're analogs of PABA.
Right. PABA, p-aminobenzoic acid, is the natural starting molecule bacteria use for folate synthesis. Sulfonamides look very similar to PABA chemically.
So they trick the enzyme?
They competitively inhibit the first key enzyme in the pathway, which is called dihydroxyapatite synthetase. They bind to the enzyme instead of PABA, blocking that initial step.
And they are bacteriostatic on their own?
Primarily, yes. They stop bacteria from making folate, which stops them from growing.
Do we still use sulfa drugs alone for anything specific?
Yes, there's one really important specific use. Sulfadiazine combined with pyrimethamine. That combination is the preferred treatment for toxoplasmosis.
Good to know. And how do bacteria become resistant to sulfa drugs?
Well, if a bug is resistant to one sulfa, it's resistant to all of them. There's complete cross-resistance. They can do it by changing that target enzyme, dihydroxyapatite synthetase, so the drug doesn't bind well, or they can make it harder for the drug to get into the cell. Or sometimes they just overproduce beta, trying to outcompete the drug.
Let's talk PK. There's an odd one, sulfasalazine. It's designed not to be absorbed well.
That's its specific purpose. It's used for inflammatory bowel disease like ulcerative colitis or Crohn's. You take it orally, but very little gets absorbed.
So it stays in the gut.
Stays in the gut, travels down to the colon. There, the gut bacteria cleave the molecule into two parts, sulfocardine and 5-aminosalicylate, or 5-ASA.
And then the 5-ASA is the active part.
Yes, the 5-ASA provides the anti-inflammatory effect directly where it's given, in the colon wall. The sulfopyridine part is mostly responsible for side effects, actually.
Interesting design. What about topical uses, burn units?
Right. Silver sulfadiazine cream is commonly used on burn wounds to prevent infection and sepsis.
There's another one, mafenide.
Mafenide acetate is an alternative, but silver sulfadiazine is generally preferred. Mafenide can cause a lot of pain when applied, and if absorbed, it can cause metabolic acidosis. Silver sulfadiazine is usually better tolerated.
Now back to systemic sulfa drugs. Metabolism in the liver creates a risk. Right. Crystalluria.
A huge risk. This is a critical PK detail. The liver metabolizes sulfa drugs, mainly by acetylation.
Okay.
Now, this acetylated metabolite has no antibacterial activity anymore, but it's often much less soluble than the parent drug.
Meaning it can precipitate out?
Exactly. Especially in urine that is neutral or acidic. It forms crystals in the renal tubules. Crystalluria. This can damage the kidneys, cause obstruction, even lead to kidney failure.
How do you prevent that?
Aggressive hydration is key.
Yeah.
Keep the urine flowing. And sometimes you might need to alkalinize the urine, maybe with bicarbonate, to keep those metabolites dissolved.
Okay, let's move on to the critical adverse effects of sulfonamides. They can be quite severe. Hypersensitivity is a big one.
Yes, ranging from simple rashes or itching, all the way up to life-threatening reactions like Stevens-Johnson syndrome or toxic epidermal necrolysis. These are devastating skin reactions.
Hematopoietic problems too, blood disorders.
Definitely. The classic one is hemolytic anemia in patients with G6PD deficiency.
Glucose 6-phosphate dehydrogenase deficiency. What happens there?
People with G6PD deficiency lack an enzyme that protects their red blood cells from oxidative stress. Sulfur drugs are oxidizing agents.
Okay.
So in these patients, the drug causes oxidative damage to the red cells, leading them to break apart hemolysis.
Important genetic interaction to be aware of.
Absolutely. And even in people without G6PD deficiency, sulfur drugs can really cause other severe blood problems like a granulocytosis, loss of white blood cells, or aplastic anemia, bone marrow failure. These can be fatal.
Now, the really critical danger for newborns, kernicterus. We need to unpack this carefully.
This is non-negotiable. Sulfur drugs are absolutely contraindicated in newborns, infants under 2 months, and in pregnant women near term.
Why? What's the mechanism?
It's all about bilirubin. Bilirubin is a breakdown product of red blood cells, and normally it circulates in the blood bound to albumin.
Okay.
Sulfur drugs also bind very strongly to albumin. They compete with bilirubin and actually displace it from the albumin binding site.
So you get more free bilirubin floating around?
Exactly. Free, unbound bilirubin. Now, in a newborn, the blood-brain barrier isn't fully developed yet. It's leaky.
Uh-huh.
This free bilirubin can cross that leaky barrier, get into the brain, and deposit in certain areas, particularly the basal ganglia. This causes permanent brain damage. That's kernicterus.
A devastating outcome from a simple drug interaction based on protein binding.
Precisely. Hence the strict contraindication.
Beyond that, sulfamethoxazole, the sulfa part of cotrimoxazole, has enzyme interactions too.
Yes, it inhibits CYP2C9. That's a major enzyme for metabolizing certain drugs.
Most importantly.
Warfarin. Inhibiting CYP2C9 significantly boosts warfarin levels, dramatically increasing the risk of bleeding. You have to monitor INR very closely and likely reduce the warfarin dose if starting cotrimoxazole.
Does it displace other drugs from albumin too?
Yes. Besides bilirubin, it can also displace warfarin and methotrexate from albumin, further increasing their free concentrations and potential toxicity.
And one last interaction reminder. Never use with methenamine.
Right. We mentioned it, but it bears repeating. They chemically antagonize each other, and the combination greatly increases the risk of crystals forming in the urine. Bad news.
Okay, let's look at the other half of the power duo. Trimethoprim. Its action is much more targeted, isn't it?
Highly targeted and much more potent against the bacterial enzyme than the human version.
What's its target?
It inhibits bacterial dihydrofolate reductase, or DHFR. This is the enzyme that performs the very last step in the active folate pathway.
Taking dihydrofolic acid to tetrahydrofolic acid.
Exactly. Tetrahydrofolic acid is the usable form the bacteria need. Trimethoprim blocks that final conversion.
And why is it safer for us? Selective toxicity.
Massive selective toxicity. It binds to the bacterial DHFR enzyme thousands of times more strongly than it binds to human DHFR. So at therapeutic doses, it inhibits the bacteria without significantly affecting our own folate metabolism.
That's clever. You mentioned its PK helps with certain infections, like prostatitis.
Yes, trimethoprim is a weak base. Chemically, this property allows it to become concentrated in relatively acidic environments in the body.
Such as?
Prostatic fluid and vaginal fluids tend to be more acidic. So trimethoprim concentrates nicely in these locations, making it very effective for treating bacterial prostatitis and some vaginal infections.
Since it does interact slightly with our folate pathway, what toxicities can we see?
Because it can mildly inhibit human DHFR, especially with high doses or prolonged use, you can sometimes see signs of folate deficiency.
Like anemia?
Yes. Specifically megaloblastic anemia, where red blood cells become large and abnormal.
Yeah.
Also leukopenia, low white cells, or granulocytopenia.
But these are reversible.
Completely reversible. And the fix is clever too. You give the patient folinic acid, also known as leucovorin.
How does that help without helping the bacteria?
Folinic acid is the already activated form of folate. Human cells can take it up and use it directly, bypassing the blocked DHFR enzyme. Bacteria, however, generally cannot transport folinic acid into their cells.
Ah, so you rescue the patient's cells without rescuing the bacteria.
Exactly. You protect the host bone marrow without compromising the antibiotic effect.
What about electrolyte issues? Potassium.
Yes, this is important. Trimethoprim has a potassium-sparing effect, similar to the diuretic amiloride. It can block sodium channels in kidney tubules,
Leading to?
potentially hyperkalemia, high potassium levels. The risk is higher in patients with kidney problems, or if they're taking other drugs that raise potassium, like ACE inhibitors, ARBs, or spironolactone. Needs monitoring.
Okay, bringing it all together. Cotrimoxazole, trimethoprim sulfomethoxazole, TMP-SMX. The synergy is the key.
The synergy is why we use the combination. That sequential blockade, hitting two steps in the same vital pathway, is much more effective than either drug alone. It makes the combination bactericidal against many organisms, broadens the spectrum, and importantly, makes it harder for bacteria to develop resistance. They need resistance mechanisms to both drugs simultaneously.
What is the single most critical can't-miss indication for cotrimoxazole?
Without a doubt, the treatment and prevention of pneumocystis jirovecii pneumonia, PJP.
Formerly PCP.
Right. It is the absolute drug of choice for treating active PJP infection, and it's the standard prophylaxis, the preventative treatment, for HIV patients whose CD4 counts fall below 200. Life-saving indication.
What other important infections does it cover well?
It's very effective for many community-acquired MRSA, skin, and soft tissue infections. That's a huge use now.
Okay.
Also good for Haemophilus influenza, though resistance is increasing. Listeria monocytogenes, causing sepsis or meningitis, and some tougher bugs like Nocardia species and Stenotrophomonas multifida. And as we mentioned, excellent for prostatitis due to trimethoprim concentrating there.
All right, our final category, urinary tract antiseptics. These feel like a direct response to the resistance problems we've been discussing.
They absolutely are. As resistance to FQs and cotrimoxazole climbed in common UTI bugs like E. coli, clinicians needed reliable alternatives, especially for uncomplicated cystitis or prevention.
And the strategy here is different. It's about localization.
Exactly. Drugs like methenamine and nitrofurantoin work because they get concentrated to very high levels, specifically in the urine, right where the infection is.
But low levels elsewhere in the body.
Yes, generally yes. This minimizes systemic side effects and, maybe just as importantly, reduces the selective pressure on bacteria living in other parts of the body, like the gut. Less pressure means less resistance development overall.
Let's look at methenamine. Its mechanism sounds almost medieval. Formaldehyde.
It's beautifully simple, pure chemistry. Methenamine itself is inactive. It comes as salts, like methenamine hippurate or mandolate. When these salts reach acidic urine specifically, urine with a pH of 5.5 or lower, they get hydrolyzed. They break down into ammonia and formaldehyde.
And formaldehyde is the killer.
Formaldehyde is a potent, non-specific disinfectant. It just denatures proteins and nucleic acids in any bacteria present in the urine. Kills them indiscriminately.
That acid requirement is key then. Sometimes it's given with something to ensure acidity.
Yes, that's why it's often formulated with hippuric acid or mandelic acid. Those help keep the urine pH low enough for the formaldehyde to be released effectively.
What's the biggest clinical advantage of this chemical warfare approach?
The number one benefit is the lack of resistance selection. Bacteria just don't develop resistance to formaldehyde. It's too nonspecific.
So it's great for long-term use.
Exactly. Its main role is for chronic suppressive therapy, preventing recurrent UTIs, especially when resistance to other agents is a problem.
Are there contraindications tied to its breakdown products, ammonia?
Yes. Because it produces ammonia, you must avoid methenamine in patients with hepatic insufficiency, liver failure.
Right.
They can't clear ammonia properly, and adding more could trigger hepatic encephalopathy.
What about kidney issues?
The mandolate salt, methenamine mandolate, is specifically contraindicated in renal insufficiency because the mandelic acid itself can precipitate. The hippurate salt is generally preferred if kidney function is borderline.
And we have to say it one more time. Don't use with sulfa drugs.
Absolutely not. Mutual antagonism and increased risk of crystalluria. A definite no-go.
Okay, last drug, nitrofurantoin, the comeback kid of antibiotics.
It really is. Introduced way back in the 50s, kind of fell out of favor, but now it's back as a first-line option for uncomplicated cystitis.
Why the resurgence?
Purely due to rising resistance rates in E. coli and other common UTI pathogens against TMP, SMX, and FQs. Nitrofurantoin, having been used less, retained its activity against many of these strains.
So it works against E. coli, Klebsiella.
E. coli, Klebsiella, Enterococcus species, even Staph saprophyticus, another common UTI bug, Its mechanism is complex bacteria. Reduce it to highly reactive intermediates that then damage ribosomal proteins, DNA, RNA, and other cell components.
And his PK is tailor-made for UTIs.
Perfectly. It's absorbed well orally, but then it's rapidly metabolized and excreted. About 40% of the dose ends up as active, unchanged drug right in the urine. High concentration where you need it, lower levels systemically.
What about side effects? Common ones?
Nausea, vomiting, diarrhea are pretty common. Using the macrocrystalline formulation instead of the microcrystalline one can sometimes reduce the GI upset.
But there are serious risks, especially with longer use.
Yes, and these are the ones that limit its use primarily to short courses for cystitis, not for kidney infections or long-term suppression generally. With prolonged exposure, usually meaning more than a month, but sometimes sooner, you can see rare but serious adverse effects like pulmonary fibrosis, lung scarring, peripheral neuropathy, and autoimmune hepatitis.
Those sound severe.
They can be irreversible and even fatal, particularly the pulmonary toxicity. This is why long-term use is generally discouraged unless absolutely necessary and closely monitored.
And this leads to the single most critical absolute contraindication for nitrofurantoin.
Patients with significantly impaired renal function must not receive nitrofurantoin, period. Usually defined as a creatinine clearance below a certain threshold, often around 30-60 millimol, depending on the guidelines.
Why is it such a hard line?
2 reasons. 1, if the kidneys aren't working well, the drug doesn't get concentrated effectively in the urine, so it might not even work for the UTI.
Right.
But more importantly, if it's not being cleared by the kidneys, the drug and its potentially toxic metabolites build up systemically in the blood. This dramatically increases the risk of those serious adverse events we just talked about, the neuropathy, the lung toxicity. It's just too dangerous in poor renal function. You must check kidney function before prescribing.
Wow. We've covered a massive amount of ground, 3 completely different ways to attack bacteria. We had the DNA replication sabotage of the fluoroquinolone,
Right, hitting gyrase and topoisomerase
and then the metabolic pathway shutdown of the folate antagonists with that beautiful synergy.
blocking folate synthesis at 2 steps with TMP-SMX.
And finally, the localized chemical assault of the urinary tract antiseptics like methenamine and nitrofurantoin.
Concentrated the attack right in the urine.
Let's try to synthesize the absolute must-know, elite-level takeaways from all this. What are the things professionals just have to have locked down?
Okay, number 1 for FQs, the moxifloxacin PK difference.
Yeah.
Liver metabolism, no renal dose adjustment needed, but poor urine levels, bad for UTIs. Contrasted with Cipollevo, which need renal dosing but are good for UTIs. That distinction is vital.
Number 2, the reason kernicterus happens with sulfa drugs in newborns, it's the bilirubin displacement from albumin crossing the immature blood-brain barrier, a devastating preventable interaction.
Number 3, the unmatched importance of cotrimoxazole for PJP treatment and prophylaxis, all thanks to that synergistic sequential enzyme blockade. Number 4, the unique advantage of methenamine generating formaldehyde in acidic urine means virtually no resistance development, making it key for suppression.
And number 5, the hard stop rule for nitrofurantoin, do not use in patients with poor kidney function due to the drastically increased risk of serious systemic toxicities like pulmonary fibrosis. Check that CRCL.
Those 5 points really capture some of the highest yield clinical knowledge from these drug classes.
Okay, so reflecting on all this, the serious, sometimes permanent side effects we see with broad systemic drugs like FQs, the cardiac risks, the tendon ruptures, the bone marrow issues with others, plus the relentless march of resistance. Here's a final thought for you, the listener, to ponder. If our big gun, broad-spectrum systemic agents are becoming increasingly risky and losing effectiveness, could the future of antimicrobial therapy lie more in developing highly targeted, localized treatments? Think along the lines of the UT antiseptics, but perhaps for other sites. Drugs that minimize systemic exposure, maybe target virulence factors instead of just bacterial growth, applying less pressure for widespread resistance.
That's a fascinating and, I think, crucial question for the future. Moving away from the carpet bombing approach of broad-spectrum systemics towards more targeted, perhaps site-specific or mechanism-specific therapies might be essential. It really highlights the challenges and the potential shifts ahead in infectious diseases.
Something to definitely keep thinking about. Thanks for joining us for this deep dive.
Always a pleasure.